Wanted to thank Dr. Flynn for inviting me. When he asked me to give a talk on stress incontinence, we talked about kind of what my treatments were. We're going to talk about surgeries, but then I did mention that I've been doing a lot less surgeries because of how some other treatments that I offer patients are reducing a lot of their urinary symptoms. And so I thought with also maybe outside of the urology community with people and other specialists doing vaginal rejuvenation treatments, why are they doing that? And where does it fit into our thinking? Okay, so as a urogynecologist, like Suzette said, so I've been finished my fellowship in 1999, and so I do everything to see a lot of patients with vaginal prolapse, urinary incontinence, but also offer reconstructive pelvic surgery. I do mainly transvaginal procedures. But I see a lot of women with sexual dysfunction, menopausal complaints, and so the first 7 years of my practice, so I was introduced to the retropubic sling in 1998 during my fellowship. Then transvaginal mesh came in 2005, and then in 2011 we got an FDA safety communication saying, hey, we should be careful with the use of mesh, and patients not wanting to have mesh put in. Around that same time, in the early part of my career, patients are also asking me, well, aesthetic questions, more sexual function questions. And as I became interested in that, in 2006, I did my first 2 labiaplasties on patients who were pretty upset by the results. So I decided I need to get better training. And so that's why I went off and concentrated more on, well, how can I do this better? I don't want to have that bad result again. And so that brought me to 2007, and around that same time, there was a lot of the ACOG and the medical communities were saying we shouldn't be doing labiaplasty cosmetic procedures at the same time that I'm being trained in this. But then fast forward to 2013, that's when I started doing my first laser procedure on a patient and discovering how it fit into my patient's complaints and how I could help them. By 2013, I realized that most of the patients that I was treating didn't want surgery to help them with their incontinence. I mean, maybe they didn't feel their incontinence was bad enough. Maybe if so obviously we offered pessaries, physical therapy, bulking agents, whatever it took to avoid surgery, we were offering. But if you think of the majority of women with incontinence, their symptoms aren't severe enough to warrant surgery. So there's really a large group of women who want to be drier but wouldn't want surgery. But then if they also wanted better improvement in their sexual quality. Maybe they wanted better sex but would never have surgery for it. Or they're having good sex but want better sex. And then there's also those patients who just tolerate their incontinence because they think it's normal for them. And we see those as well. And so in November 2013 was the first time I did a laser on a volunteer. Didn't know what it was for. I was told this is for vaginal tightening. I thought that's not going to work. There's no way. You need to surgically tighten someone to make them tighter. But these patients came back saying, oh my gosh, sex feels better. I have better lubrication. I'm not leaking anymore. It's like, holy cow. So you're not having incontinent anymore and you're having less bladder infections. So there's a kind of, the more and more I did these treatments, I realized there's a role for certain categories of patients depending what their complaints were. And so in 2015, I was introduced to PRP, mainly to improve orgasm function, and then in 2017, radiofrequency came around. And what I saw is, yes, there could possibly be an improvement in lubrication, sensation, pleasure, and also when these treatments are done to the vulva, there's improvement in appearance, but their bladder symptoms improved. And so then, it's a different slide. So some of the devices, whether it's CO2, different lasers, and radiofrequency devices as well. The questionnaires that are available, so I think one way of finding out what the patient's symptoms are, what's important, is having them fill out a questionnaire. We're all used to the urology questionnaire, bowel function questionnaire, sexual questionnaire, and then actually looking at, giving them an opportunity to explain to you what their complaints are before, to better understand how you can help them. So if you look at the left side of the slide, if they're only there for stress incontinence, then we already know, and we're going to go over all those great treatments for it, and let the patient choose what treatment she wants. Especially if there's no prolapse, no sexual concerns, or maybe they're not sexually active, then you will end up deciding whether maybe it's just a physical therapy is all she needs, bulking, or a sling. But if her list of complaints and priorities are more, I want to improve my sex, oh yeah, by the way, I leak urine, that's not so much of a problem for me, but I want to improve the quality of my sexual relations, then that's where my mind comes in and offering laser, radiofrequency, and also PRP. And so if you think of, now we're looking at the patient from the entire patient, not just in isolation for one stress incontinence symptoms, because every patient who has stress incontinence may potentially have other complaints that we should address. So our traditional treatment modalities, whether it's Kegels, biofeedback, pessary, bulking, slings, and then putting the regenerative treatments being CO2 fractioning, resurfacing, radiofrequency, and also platelet-rich plasma. And so this is, so you know, what does the laser do? So when we treat the vagina with a laser, it intentionally ablates the vaginal tissues, and the fractional treatment means it creates injury spaced apart in the area that you're treating, but it leaves the majority of the vagina is not injured. And so then healing begins, and then new collagen sets in. So this is a good photo of what one ablative treatment of one area is. A 9 by, for example, here's a 1 centimeter area with 81 intentional injuries to the vaginal tissue for it to heal. And this is an example. So earlier this morning we saw a great talk on GSM showing what a trophic vagina looks like and one that's premenopausal. So this is an example of how it regenerates the tissues. So we're trying to improve the vaginal health. And also, of course, we would do these treatments only after we've already tried estrogen. So platelet-rich plasma, it's been around for over 20 years. It's used for in dentistry, it's used in orthopedics, but now I've applied it into the vagina. And the idea is to, when you activate the PRP with calcium chloride, what we'll do is it'll release the growth factors within the platelets and start the regenerative healing. So we can inject the PRP directly into the clitoris, into the vagina, or into any tissues that you want to heal. And it creates a cascade of events that repairs and regenerates tissue. So in my practice, one of where I first used it is in performing the O shot to improve orgasms. You would think that would be painful, but it's done in such a way where it's not painful at all. But imagine hundreds of thousands of platelets injected directly into an area to improve blood flow, improve function. But I've also used it in patients with pelvic pain. So if they have entry pain that estrogen cream isn't helping, urethral pain, injecting it along into the anterior vaginal wall helps with the urethral dysfunction, helps with nocturia. So now, if the symptoms are predominantly avoiding dysfunction issues as well, and they want improved sex, then that's where these treatments come in. This is a monopolar radiofrequency device that's being done. This purpose is to improve sensation at the opening, but it also helps with stress incontinence. So these patients will notice reduced symptoms. And then these are other examples of other radiofrequency devices. This one actually is electrical muscle stimulation. This is another device that does non-ablative radiofrequency. And then you can have like fractional CO2, you can do fractional radiofrequency treatments where these needles go into the vagina 1 to 3 millimeters deep to ablate the tissues, heat the tissues, and again, intentionally injure for it to then heal. So this is showing how the needles will go in and then the heat is delivered and it creates the ablation. And that just shows the ablation, the coagulation, and nonspecific heating, all to create more injury. Now, the cons in this, it's cost. It's not FDA approved for these indications, but we see improvement in symptoms. So the pros would be the patients are looking to improve their symptoms that may not want a surgical intervention, and also hoping to improve their sexual function. my slides were rearranged. What I wanted to discuss is, initially when I started learning about doing cosmetic procedures, is the fact that at that same time, ACOG came out with a committee statement as I was being trained, saying, oh, you should be careful, we shouldn't take advantage of patients, and these surgeries may not be effective. But the whole point is surgeons should be properly trained, properly selecting patients, and just let patients be aware of the pros and cons of these procedures. But thank you.